Hello everyone, Floyd here. I want to talk to you a little bit about mechanical CPR. Specifically, I want to discuss this concept of mechanical CPR being a life-saving treatment and the theory that since it performs CPR better than we can, we should apply it early, as soon as possible. In EMS, we have a tendency to rush to adopt something to maintain a progressive status without considering that might have some unintended consequences, and we often do it without proper implementation. And I think that this is absolutely the case with mechanical CPR. Now, as you're probably aware, there are two mainstream devices, and these devices assume different mechanisms of CPR. Those are the Autopulse and the Lucas. And just full disclosure, I have no hands-on experience with the Autopulse, but I have a lot of experience with the Lucas device. Now, the Lucas device operates mostly based off of the cardiac pump mechanism or theory, which is probably the only mechanism that most people are really familiar with. And that is that we are actually compressing the heart when we perform CPR, which squeezes blood into arterial and pulmonary circulation. The aortic and the pulmonary valves open up, allowing forward blood flow from the heart, and then the other valves, the mitral and tricuspid, close, which prevents retrograde flow back into the heart. The autopulse seems to operate mostly based off of the thoracic pump as opposed to the cardiac pump theory. And the thoracic pump theory is the theory that the airways collapse during CPR, and this collapse causes an increase in intrathoracic pressure, which then prevents retrograde flow back through the collapsed venous structures. To be completely accurate, I believe that the autopulse is also designed to compress the heart as well to a degree. Now, which mechanism is correct? Well, honestly, it's probably a little bit of both. In patients with so-called barrel chest, as you can imagine, the heart sits a little further from the chest, so it stands to reason that it would be more difficult to effectively compress the heart. And in young patients with a narrow chest wall, blood flow during CPR is mostly secondary to cardiac compression. And in those patients with the so-called barrel chest, it's probably the thoracic pump mechanism that promotes most of the blood flow. Now, many often say that they've seen the device work, that they've seen patients survive, that they've seen they've had these miraculous saves. But neither of these devices have proven to increase survival to discharge from out-of-hospital cardiac arrest. A meta-analysis from Gates et al. Says this doesn't happen. Now, the optimist would say, well, if it's not any better but not any worse, then why not just use it so that we can dedicate less people to an arrest and focus on other things? And I think the main reason is that there's actually evidence that mechanical CPR is inferior to manual CPR. An article was recently published last year called Out-of-Hospital Cardiac Arrest Outcomes with Pit Crew Resuscitation and Scripted Initiation of Mechanical CPR compared to scripted CPR with scripted mechanical CPR application. And I like this study because they compared high performance or pit crew CPR to scripted initiation or integration of mechanical CPR. What they found was that mechanical CPR was actually associated with decreased ROSC and decreased survival to discharge. So you may be wondering, how could a device marketed as this life-saving device not be doing everything that we expect it to be? Now, I think that there are a few different purported reasons, and they mostly explain, or they help explain, why there's not better outcomes with a cardiac pump mechanism, aka the Lucas device. So the theory that I'm going to get into now hinges mostly on the cardiac pump mechanism, not the thoracic. Although some of the other theories as to why mechanical CPR is not better, is applicable to both. So to really understand this, we have to discuss physiology a little bit more. So we know based off of work by, and I'm going to butcher his name, Huang et al., he showed that standard CPR, i.e. the intranipple line, often results in compression or narrowing of the left ventricular outflow tract or the aortic root, which is not what you want when you're performing CPR. You want the compression to be over the left ventricle and not the aortic root. In this study, the area of maximal compression was over the aorta in 59% of patients. So in more than half of the patients, they were compressing basically the aorta. In yet another study, Anderson et al. Used transthoracic echo to mark the location of the aortic root and the left ventricle in animals, and then they randomized those animals to receive CPR at either of the two locations. And as you can probably guess, when you compress the left ventricle, pressures are going to be higher. So aortic, systolic, and diastolic pressures and end-tidal CO2 were higher in the left ventricle group. 9 of the left ventricular group, which was 69% of the sample size, achieved ROSC and survived about 60 minutes, or at least 60 minutes compared to no survivors who received chest compressions over the aortic root. Now, this is just one of the reasons that I think that the Lucas device has not shown an increase in survival and has shown worse survival compared to scripted CPR. The device is too consistent. Humans are likely to not compress in the exact same place every time, every single time, all the time. So it's possible that the Lucas is simply compressing the aorta if it's placed properly per the instructions, internipple line, the vast majority of the time. It's also possible that we could be compressing the aorta if we perform manual CPR the vast majority of the time. Clearly, the internipple line is not always the best place. Of course, just as there are 2 mechanisms of CPR and one may be better than the other depending on the patient, what's good for one patient and it isn't always what's best for another. There was another article called A Clinical Pilot Study of Different Hand Positions During Manual Chest Compressions Monitored with Capnography. This was very interesting. This was conducted by a physician-staffed ambulance, and they enrolled 30 patients, so a small sample size, not a whole lot of patients. But their findings were pretty interesting. They performed 1 minute of CPR at the internipple line, followed by 30 seconds of CPR 2 centimeters below the internipple line, followed by 30 seconds of CPR 2 centimeters below and left of the internipple line, and then they performed 30 seconds of CPR below and to the right of the internipple line. And then they monitored the end-tidal CO2 for changes. What they found was that the hand position that reflected the highest end-tidal CO2 was extremely variable. So in the internipple line, 10 patients had the highest end-tidal CO2. 2 centimeters below the internipple line, 7 patients had the highest end-tidal CO2. Below the internipple line and to the left or the patient's right, 4 patients had the highest end-tidal CO2. And then 2 centimeters below the internipple line and to the right or the patient's left, 4 patients, 4 others had the highest end-tidal CO2. Okay, so earlier I said there were a few reasons that some think that mechanical CPR isn't associated with increased survival. One major reason purported is that when do we usually place the Lucas? Well, you should probably say, if your system's like most, as soon as possible, and that kind of makes sense. If it does better CPR, why not place it early? But when are you most likely to obtain ROSC? Well, you should also say that you're most likely to obtain ROSC early in the resuscitation. Now, your system may be catching on like many others and defer the application of mechanical CPR. And if you are, that's great. I've talked to multiple EMS executives at other services, and they are setting a fairly strict Lucas application time standard so that the Lucas is deployed later rather than earlier. You may also say that you can apply mechanical CPR regardless of the device in under 10 seconds, or that you can apply it with a total pause in compressions of less than 10 seconds. Anecdotally, this is not the case. You may be able to do that on a mannequin, and you may be able to do it on a select few patients, but the vast majority of the time it takes much longer, or you have to stop CPR much longer than 10 seconds to deploy the device. So I think we have at least 2 good reasons to defer Lucas application. In some systems, they may even want to place the Lucas before providing defibrillation, and I think that should absolutely not happen unequivocally. I do think that mechanical CPR saves lives. If you're in a system that transports patients in cardiac arrest, then for your safety, it's an absolute must. If you're in a system that transports patients intra-arrest to a center that will take the refractory VF patient straight to PCI, and you can actually show that your refractory VF patients are being taken to PCI and that there's measurable improvement, then I think that is reasonable. But you should still focus on proper integration of mechanical CPR into pit crew resuscitation. There are multiple other reasons for early mechanical CPR application, but I'm not going to go into all of those reasons. But I think that if you want to improve cardiac arrest survival within your community, you need to consider whether your life-saving interventions are truly life-saving. And that's all for now. If you have any questions, let me know at Curb2Bed on Twitter, Facebook. You can also email us, curbtobed@gmail.com. Bye for now.